Okay, so let's start with the webinar dedicated to prostate cancer. My name is Morgan Roupré. I'm an academic urologist and I work in Paris, France. I'm also the chair of the European section of onco-urology of the EU. I feel privileged to be surrounded by two talented speakers tonight. I will start, as I am polite, with my colleague, with a woman, Elena Castro from Madrid, Spain. She will be introduced first, but she will speak as a second lecturer. She's a medical oncologist, especially focusing her talent on GU tumors at the Virgin de la Victoria University Hospital in Malaga, Spain. And we are very happy to have you, and she's a member of the ESMO. Thank you, Elena, for being there tonight. And we have also with us Professor Nicolas Mottet, who is a famous urologist from east part of France in Saint-Étienne, but also the chairman of the guidelines of prostate cancer. So all together, we'll try to have a discussion around the topic, which is highly interesting. The management of non-metastatic castration-resistant prostate cancer. It's a moving field. There is a lot of evidence, new trials, phase 2, phase 3. The guidelines are changing, the practice is changing, and what we try to do tonight is to put current evidence into, I would say, daily practice, from bench to bedside. So without any more time, I think we need to jump into the first topic, which is what we call the summary of the evidence in the field of non-metastatic castration-resistant prostate cancer. So I leave you the floor, Nicolas. Do not hesitate for the participant to use the Q&A to raise your points. And after this webinar, which has been organized by the School of Urology, you will have a link to evaluate the quality, I would say, of the discussion, of the dissemination of the evidence, and how you enjoyed this session tonight. So we have now nearly 130 participants. Nicolas, the floor is yours.
Thank you, Morgan. Good evening, everyone. Good afternoon, everyone. So it's my pleasure to try to summarize the evidence behind the management of non-metastatic CRPC. My disclosures with the pharma industry, as you can see, almost all the drugs are there. So there's a very simple general principle in CRPC that everyone needs to remember, that an ongoing castration is mandatory. Despite the fact that it's purely evidence-based, the rationale behind that is based on very limited data, but all the trials I will show you had an ongoing castration. So make it simple, keep going with the castration. That's the easiest way to go. What are we discussing? Castration resistance. What is castration resistance? Well, it has a definition that first starts with you need to be castrated, and castrated means you have a testosterone level that is below 50 nanograms per deciliter or 1.7 nanomole per liter. So that's definitely the first thing to do. And as we're dealing with non-metastatic CRPC, the only signal of progression is a biochemical progression based on PSA. But it's not every PSA progression that counts. There are two criteria there. The first one is the PSA must be above 2 nanograms per ml. If it's below, it doesn't mean anything, at least from evidence. And second, it must be rising, and it must be at least twice 50% increase over the nadir. These two criteria are absolutely important because they were always selected for the trials. So remember, check the testosterone and have a PSA rising and above 2. We know a lot of things about non-metastatic CRPC natural history. The first one is, and you will see a lot of data are coming from Matt Smith from the US. The first time is the median time between the definition of non-metastatic CRPC to bone metastasis is roughly 25 months. You see this on the curve. That is a control arm of a randomized control trial, and clearly, after it's roughly the metastases altogether are rising after a median of 2 years after the definition of the non-metastatic CRPC. The second thing we know is that there's a link between the time to metastasis and the PSA doubling time once you're castrated resistant. And clearly you see again from Matt Smith, a different control arm from a different trial, that when the PSA doubling time is below 6 months, the time to metastasis, median time to metastasis is roughly a year. When it's between 6 and 18 months, the median time is roughly 2 years or 2.5 years. And if it's above 18.8 months, PSA doubling time again, the median is probably much longer than 3 years. So clearly, this suggests that the non-metastatic CRPC is an heterogeneous group of patients, some of them with very early metastasis, some other with late metastasis. This was split between 3 categories, but the most important thing is that if you purely check the PSA doubling time of 10 months, and you will see why I was referring to these 10 months, it's absolutely on purpose. The median time of the PSA doubling time in this cohort was 9.7 months. That is roughly 50% of the non-metastatic CRPC patients have a PSA doubling time below 10 months, and 50% have a doubling time above 10 months. Remember this 50% above 10 months. The third thing is that there's really a change in the curve slope around 10 months. You see, these slides have been seen repeatedly, and again, come from Matt Smith, from a paper in the JCO, published in JCO 2013. Again, a randomized control trial, a very large cohort, 716 men. And you clearly see this, the threshold that where the curve is changing is around 8 to 10 months. If you go again with this cohort, you again see the time to metastasis is directly linked to the doubling time. Not a surprise, the curve in yellow is the one with men with doubling time below 10 months. This is time to metastasis or death, but it's not the link between the doubling time and the survival. This was not reported by Mike Smith, but it is reported in this completely independent cohort from Howard, published 5 years ago, around 5 years ago for 400 men. A completely independent cohort showing again a direct link between the doubling time and the metastasis. But for me, the interesting thing is it also links the doubling time and specific survival and overall survival. And just to highlight how important it is, when you have a doubling time of more than 15 months, the median time to death is longer than 60 months. On the opposite, when the doubling time is between 3 to 9 months, the median survival, the median death rate is roughly 3 years. So once again, it strongly suggests that it's a very heterogeneous group of patients. We are very fortunate because we have now 3 randomized controlled trials, all sharing a lot of things. They are all based on M0 patients, always defined based purely on bone scan and CT scan. There's a slight difference in terms of N1 status that were allowed in Spartan and the Ramis trial that were not allowed in Prosper, but all the rest were absolutely based on bone scan and CT scan. All the patients had a PSA above 2, and all the patients had a doubling time below 10 months. This was a constant inclusion criteria. In the trial, there was a stratification based on the PSA doubling time, based on the fact the patient used bone protective agents, and for those who included N1 disease, there was stratification between N0 and N1. The randomization was always 2-to-1, a drug daily versus a placebo. And the primary objective of these three trials was mets-free survival, metastasis-free survival, or death. Imaging was done on a very regular basis every 16 weeks, and it was purely conventional imaging, that is bone scan and CT scan. So three trials that look very similar, but include completely independent patient cohorts. Regarding the primary objective, that is mets-free survival, you have the three trials there. On the left, the first one that was published with apalutamide. You don't need to be a super statistician to see the huge difference between the apalutamide treated group and the placebo arm. 40 months versus 16 months hazard ratio. Hazard ratio is 0.28, a difference on 24 months median time to metastasis. The second trial was PROSPER with enzalutamide. Again, a huge difference, a hazard ratio of 0.29, the difference in mets-free survival around 22 months. The third trial is the ARAMIS trial with darolutamide. The median time benefit is 22 months with darolutamide compared to placebo, with a hazard ratio of 0.4. As you can see, the vast majority of months, three trials, three very positive trials, but be very careful. These three trials are completely independent, so you're not allowed to compare there directly. You cannot say drug A is better than drug B or drug C. Three trials, absolutely positive. The benefit seems to be in the same range for the three drugs. All the trials also had secondary endpoints, and I just selected some of them that for me are very important. Let's again start with Spartan again, because it was the first one to be published. The time to symptomatic progression, on the bottom left, you see the huge benefit with apalutamide compared to placebo. For OS, it was not there at that time, 2018, first publication, time to PSA progression, clearly different. With PROSPER, with enzalutamide, you also see a huge difference in PSA progression, and you use an anti-neoplastic drug. And with darolutamide, with the ARAMIS trial, again, a huge difference in first time to symptomatic skeletal events. You see the hazard ratio is 0.43, the p-value is below 0.01, the time to cytotoxic chemo and time to pain progression with the p-value far below 0.5. So clearly, all the secondary endpoints were there and clinically meaningful, delaying symptomatic progression. But even more important is the overall survival results. These were published. This was not the primary objective of these three trials, but all the three trials showed the same thing: a clear overall survival benefit with APA, with ENZA, and with DARO. Again, the hazard ratio for survival is always in the same range. You clearly see a huge difference in terms of survival. The median is not yet reported with the ARAMIS trial, just because it has the shortest follow-up, but the hazard ratio is clearly significant and always going in the same direction. So there is no discussion. You delay the mets, you delay symptoms, and you improve the survival with one of these three drugs. Even more, once again, three independent trials, you cannot compare them directly. But even more important, as you know, there was a placebo control arm. After the first analysis, a crossover was allowed, and the benefit remained despite the crossover. For example, you see the curve for Spartan, and the crossover is not trivial, up to 30% in ARAMIS, and these results are presented as intent to treat. That is, the patient reported in the placebo arm, in the placebo curve, are those who initially received the placebo. So despite the crossover, the survival is there, which is very important. There might be a price to pay in terms of quality of life. That's a very simple data, because Elena will discuss that in details. Apparently, the quality of life is flat with all the three drugs. What does it mean? it means that there doesn't seem to be a huge detrimental effect in terms of quality of life with either of these three drugs. Again, no direct comparison. This has led to a very simple guideline recommendation, and as you can see, it's a strong recommendation. You need to offer either APA or DARO or ENVA by alphabetic order in patients with nmCRPC based on conventional imaging and high risk, that is a PSA doubling time below 10 months, as it prolongs time to metastasis and increased overall survival. I don't hear you, but you said M0. Well, this is only based on bone scan and CT scan. Some patients were also selected based on MRI, but none of them were staged with PET PSMA. We clearly know that it's absolutely suboptimal in terms of sensitivity. And this has raised a question by Oliver Sartor in the New England Journal that does the nmCRPC status really exist? And this came after this paper was presented by Fendler, Clinical Cancer Research 3 years ago. All the patients that are Spartan-like population, all of them were M0 based on conventional imaging, all of them had a doubling time below 10 months, all of them have a PSA above 2. And you can see 89% has a positive PET PSMA, and roughly 55% were in fact M1 based on this PET PSMA. This raised the question of what would be the added value of PET PSMA in this cohort? What is the practical impact, especially when we now have overall survival benefits without PET? The only benefit would be to use ABI, absolutely no data, or to use DOSE, absolutely no data, purely based on the PET PSMA. This is for the doubling time below 10 months. I don't know a single paper dealing with patients with non-metastatic CRPC and PSA doubling time above 10 months. We have absolutely no data on that, but remember, there might be, if you use it, you might have a major lead time bias of more than 2 years. So you need to be very, very careful because jumping to this kind of therapy in these patients. What do we do in practice with those men with a doubling time above 10 months? Well, there's no randomized trial, there's no level 1 evidence. The only data we have is purely consensus-based, quite an old consensus, which is easy to say, sometimes more difficult to be accepted by patients. What does it say, this consensus? Don't change the treatment, repeat imaging every time the PSA doubles or when there are symptoms, and treat at the time of metastasis. So that's what we have, and that's what we have in the guidelines so far. And I just want to finish, to be perfectly on time, to remind you 2 things. The first one, I already said it. When you see a patient treated with ADT and a rising PSA, the first thing to do is to check the testosterone level. If it's above 50, it's not a castrate-resistant. It's a non-well castrated man. And the second thing that you know that there have been changes in metastatic CRPC situation, that when the patient is non-metastatic CRPC, you might begin to think about somatic or germline testing. It won't have any impact immediately, but in few months or few years later on, it might have some. And the ongoing ADT is absolutely standard of practice. Thank you for your attention. Happy to answer any questions.
Thank you. Thank you, Nicolas. Can you hear me correctly? Yes.
Yes.
No particular question popping up from the Q&A, if I didn't miss anything in the tool. But what I would like to do first thing is to congratulate you. You attract the audience. We started the presentation with 130 people. We are nearly 200 now. And there are from the Q&A popping congratulations coming from the colleagues. Amazing presentation. Thank you. Just maybe one very straightforward question for you. According to the natural history of the disease, we can consider several, I would say, endpoints in trial dealing with prostate cancer. What is your feeling now dealing with these important trials, important data that you have presented? What is the most meaningful endpoint that you are considering at this stage when you look at the trial and when you try to read between the lines? Because there is always a presentation from the pharma and the partners, but we as physicians, what is the most important and impacting endpoint?
Well, probably you won't be surprised if I tell you it's the survival, but before the survival was available, what impressed me, it was not the mets-free survival benefit, it was a symptom-free survival benefit. Because if you don't check the patient regularly with imaging, as long as it remains asymptomatic, he doesn't know he has imaging. He has metastases. When he has symptoms, then he knows something is going wrong. So for me, the most attractive things, apart from survival, is the benefit in symptoms, which is seen with the 3 drugs. And as a clinician, it's the most relevant thing, I think.
Thank you, very clear. I think for the sake of time, I will keep the questions that are now popping up in the box so we can have room for discussion after the presentation of Elena. So Elena, if you're happy, we start with your presentation, which is extremely important because we know that when we translate the data into real practice, we need also to deal with the quality of life of the patient. We need to deal with the side effect and the potential toxicity. And I think that in the field of onco-urology, this is something that we take more and more into account in the way we discuss with the patient, because they are seeking for information, website, colleagues, and so on. So I would like to see how you consider this important, I would say, criteria in the way you manage your patient. And then we'll have, I would say, room for discussion. Thank you, Elena, for being there tonight.
Thank you for inviting me. It is my pleasure to be here today and to discuss the adverse events and quality of life related to the use of apalutamide, enzalutamide, and darolutamide for the treatment of patients with non-metastatic castration-resistant prostate cancer. These are my disclosures. And as Professor Motet already presented, we know that the efficacy of these 3 therapies is very similar, and safety profiles have been invoked as the primary difference between these 3 drugs. So I will start by reviewing the side effects and quality of life data reported in the 3 phase 3 trials. In the SPARTA trial, almost all patients included in the trial presented some kind of adverse events that were grade 3 or 4 in 45% of patients treated with enzalutamide and 34% in patients in the placebo arm. And these adverse events lead to treatment discontinuation in 11% of patients and 7% of patients in the treatment and placebo arms, respectively. So the most frequent side effect with apalutamide was fatigue, that was observed in 30% of patients who received the treatment. And in most cases, almost in all cases, it was grade 1 or 2. Hypertension was observed in about 25% of patients that reach grade 3 or 4 in about 14% of patients. Rash was present in a quarter of patients treated with apalutamide, and other side effects such as diarrhea, nausea, weight loss, arthralgia, or falls were observed in between 15 to 20% of patients. And other adverse events of interest that were reported in less than 15% of cases were fractures, dizziness, hypothyroidism, and cognitive impairment. Multiple tools were used to assess quality of life in the trial. It is true, and it's been discussed, that these tools, or at least some of these tools used to assess QOL, were not developed for asymptomatic or minimally symptomatic patients usually are our patients with non-metastatic CRPC, but probably some of them were not the best tools. But these are broadly used, have been validated in many trials. And what we get from the quality of life analysis from the Spartan trial is that the main scores that that were self-reported by patients reported overall health-related quality of life, including physical, social, family, emotional, and functional well-being that was maintained from baseline to cycle 29 of treatment. And here in the bottom, you can see in these graphs how are the changes from baseline in this score, and you can see that the deterioration in quality of life, if anything, was more pronounced, more apparent in the placebo group. And here you can see the changes from baseline for a couple of items in one of the scales, the FACT-P scale. And these single items were whether the patient is bothered by side effects of treatment and whether he has a lack of energy. And despite most patients on apalutamide presented adverse events of different kind and degrees, most of the patients, as you can see here, were not bothered by the side effects they experimented. And this bother did not change over time. So it did not get worse with the treatment. And likewise, fatigue, which was indeed the most frequent side effect observed with apalutamide, did not get worse over time, and actually in some patients even improve, as you can see here represented in green. So to me, this means that patients seem to be tolerate these therapies, this therapy apalutamide quite well. In the case of the PROSPER study, treatment with enzalutamide, all patients included in the PROSPER trial, either in the treatment or control arm, experimented some adverse events, like in the previous trial, that in this case reached grade 3 or 4 in half of the patients treated with enzalutamide and a quarter of patients in the placebo group. So adverse event leading to this treatment discontinuation was 17% and 9% respectively. And in this case, the most frequent side effects were again fatigue, that was present in half of the patients treated with enzalutamide. Musculoskeletal events were also frequent, and that included back pain, arthralgia, myalgia, or muscular weakness. Hypertension, falls, and fractures occur in about 20% of patients treated with enzalutamide, and cognitive and memory impairment occur in 8% of patients. Cardiovascular events were reported in 6% of patients, and rash was only reported in 4% of patients. Similar to the Spartan trial, patients included in PROSPER were generally asymptomatic at baseline, and they maintain very good quality of life during the treatment period. So the scores remain quite stable, and enzalutamide, and you can see in these two graphs, improved time to clinical deterioration as measured by means of 2 different scales in this case. So again, very good quality of life related to the use of enzalutamide. And finally, the ARAMIS trial. So again, the majority of patients included in the trial also developed some side effects or some adverse events. If anything, it seems the reports were slightly lower than in the previous study. And in the Aramis trial, a similar proportion of patients in the treatment and placebo arms experimented side effects that lead to treatment discontinuation. It was 9% in both arms. In this case, fatigue and asthenia was the most frequent side effect again, and it was observed is the only side effect that was present in more than 15% of patients. Hypertension and arrhythmia were both present in about 8% of patients, and other side effects were reported in less than 5% of cases. And similar to the previous therapies, treatment with darolutamide resulted in a well-maintained quality of life and a delay in time to deterioration in both prostate cancer-specific quality of life and disease-related symptoms compared to placebo. So as Professor Motet said previously, we should not compare directly these trials. But just let me say something here. It is true that it was the Spartan trial, the one that reported more side effects, and it has been with darolutamide that less toxicities have been observed. And even when we have very clear that we should not compare trials for the purpose of efficacy and survival and etc., we often tend to do that in terms of toxicity and reported side effects. And this difference for darolutamide has been explained because darolutamide has a different molecular structure that is characterized by a low blood-brain barrier penetration, and that may result in an improved tolerability. But let's go back to the trials. And I just mentioned that there's been more side effects reported for this Spartan trial, but the truth is that it was not only for patients who received the therapy, it was also for the patients in the placebo arm. So if, as Professor Motet presented, these trials were conducted at the same time, had almost the same inclusion criteria, the study designs were almost identical, the different incidents of side effects in the placebo arms in these three studies highlights the likely different assessments used in these trials. And with this, I would like to draw your attention to this publication in which the authors aim at investigating whether there was a meaningful difference in toxicity profiles of these three drugs that we can really, whether we can really, from the data that has been published, be sure that there is a real difference in toxicity. And the first conclusion is that a rigorous comparison of the drug safety is not possible from the data reported due to the heterogeneity in adverse events reporting and the variation in the adverse event risk that has been observed in the placebo arm, among other reasons. So they focus on the placebo arms, who are patients who were not affected by the study drug, to assess the drug-independent and methodological factors. And they observed that the more scheduled visits were associated with a higher adverse event reporting in the placebo arms. And for that, if we look here at the study characteristics, we see that Spartan was actually the trial with more scheduled visits compared to Prosper and Aramis. And this, the author of this study also conclude that it is not clear whether a longer follow-up was associated with a higher risk of adverse events of any type. And they also calculated the relative risk of the most frequent side effects. So they compare how likely or how much risk have patients within each trial of developing fatigue and hypertension when they receive the different drugs compared to the placebo in the same studies. And with this, they observed that the risk of fatigue was 44% increase in patients receiving apalutamide versus those not receiving the drug in the placebo arm, which is quite similar to the 39% in the ARAMIS trial for darolutamide. And it was significantly higher for the patients who received enzalutamide in the PROSPER trial. And a similar observation was also made for hypertension, with a 25% increase in the Spartan and ARAMIS trial, and a significantly higher increase for patients included in the PROSPER trial and treated with enzalutamide. And the next is my last slide. I would like to also remark that there is a significant difference between the three drugs also in the probability of a drug-drug interaction, and this may be related to the different molecular structure of these drugs. This is, I think, is very important for our patients, because even when they may be minimally symptomatic or even asymptomatic, they often have many comorbidities and require different therapies for these other conditions. And the drug-drug interaction could lead to a lower efficacy of the treatment for these other comorbidities, or an increased risk of adverse events. So in this respect, darolutamide has shown a favorable drug-drug interaction, while enzalutamide and apalutamide have a larger number of potential drug-drug interactions. This was my last slide, and I will be very happy.
Thank you very much, Elena. It was extremely interesting, and you went into many, many details that are really meaningful for our daily practice. I think that Nicola could come back also, so he can join the discussion. First thing, as mentioned in your slide, we want to officially acknowledge the fact that the pharma company Bayer is supporting our event tonight. And if anybody has missed the event, there will be a replay on the YouTube channel of the School of Urology. So if anybody attending the event thinks that somebody would benefit from the information we are discussing tonight, do not hesitate to share the link. And there will be also a link for the evaluation of the content and the quality of the presentation. It's absolutely important for the school and for ourselves to get the feedback from the attendees. So, Elena, once again, thank you. There are some questions popping up from the box. I think you can see these questions, but I will, if you don't mind, go to you and Nicola, and we'll try to answer as quickly as we can within the remnant time that we have ahead of us. So one question to Nicola, maybe, what is in your mind the best method of testosterone measurement for the patient, and what period of the day I would add?
The period of the day, that's a nice question. Never even consider that. In that case, there's a circadian rhythm of testosterone, but when you're castrated, I don't know if there is still a circadian variation of testosterone. Well, the issue with the testosterone, that everything started with the old definition of castration, that it's 50 and below, and now we have methods that are able to check for point something nanomole, which is far, far, far below 15 nanograms, which is again 1.7. So at least I would suggest to remain simple. Is it 50, or is it above 50 or below 50 nanograms per deciliter? Whatever the method you use, because this is the labeling of castration for drugs. Make it simple. Okay, clear.
Elena, maybe you can take the next one regarding or maybe I can have I would say the point of view from both of you regarding new molecular imaging and TEP. This is the big discussion, because we know that we have built trial with a methodology or population of inclusion where we have used what we call the old-fashioned, I would say, workup that we use traditionally. And the question that is coming there, but it's an ongoing discussion that we have in all the sessions, is whether or not we should incorporate, I would say, PSMA PET in the contention upon the fact that it is available in the country where we practice. So we have difficulties in France. I don't know how it goes in Spain and for the countries of the people listening to us. But in your mind, does it play now a major role in the future of these patients, or do you see, do you consider that we have robust data from the trial and that the PSMA PET is likely to confuse a bit the way we are going to treat this patient and discuss their cases at the tumor board?
If you ask me, yeah, I think PSMA PET is very relevant. It's something that we will need to. It's a very useful tool. The problem we have with advanced disease is that we probably don't have enough evidence to change management at present based on the data we have. But I think it is probably we need to incorporate PSMA PET to studies and trials to get whether, considering the results of these new technique imagings and changing our practice, really results in a change of patient outcomes.
Thank you. Would you like to add some extra words, Nicolas, from your, what is your philosophy towards PET imaging?
Make it simple. In this stage on CRPC, except if in real practice, except if you want to use a MET-targeted therapy like radiotherapy to the METs, to the spots of the prostate. We don't have any evidence to support that. We don't know if it's changed anything. So I would make it very simple. For me, PET PSMA at that stage has absolutely no place in everyday practice. It has a role in trials, but trials is not everyday practice. Trials is a trial where you ask a question. I fully agree with Elena. It might be of interest, but outside the trial, it's just a waste of money.
Okay. One other point is, yes, clear, crystal clear. One other point is the advent of these new drugs, oral drugs, new generation of, I would say, hormonal therapies with APA and Daro. We have no head-to-head comparison. We have very important trials. So is there a way, Dr. Castro, in your mind that you are going to, I would say, have a criteria, a main criteria of decision to choose between these three drugs, the most appropriate therapy option? Do you have a profile of patient that fits more with Daro, APA, or ENZA? Or it's up to, I would say, personalized medicine, and I would say each patient case is extremely different. So how do you choose? How do you make your own choice?
Yes, considering that the three of them are available and depending, of course, on the patient, I think the drug-drug interaction to me is an important issue. So if the patient in front of mine is a patient with several medications for other things, I may consider darolutamide just because it's easier not to find an interaction with another treatment, with another therapy. If it's an elderly patient or a patient that has already some cognitive issues, or then probably I will avoid enzalutamide, for instance. But in other patients, probably any of the three, in terms of efficacy, the three of them have demonstrated more or less the same results. So it also may depend on what you have reimbursed, what is available in your center, or probably what do you feel more confident using your experience if the patient, reducing doses based on the side effects the patients may present? So I don't know, this is what I usually do, but what is it that you do, or what is your experience with these drugs? How do you choose?
What about you, so Nicolas, and especially in a patient, for instance, which has, I would say, severe, comorbidities, concomitant treatments? Are you targeting one drug in particular? And I have in mind darolutamide, which is popping up from the question also. Or do you have any, as you like to make it simple, any pragmatic behavior towards these three drugs?
Well, I fully support what Elena said. And to make it simple, I take my cell phone and I give a call to the pharmacist who knows better than I about drug-drug interactions. And to be honest, very often I'm disappointed because the feedback is very often, you will have interactions whatever you do and whatever drug you choose. So, but if it's a potential major interactions, then despite the fact that I'm disappointed by the answer, I ask my pharmacist, sometimes they have sometimes quite good advice. I don't know all the interactions by heart, and the computers to use it is not very well working where I work. So.
Okay, perfect, extremely clear. I'm looking at the last question, but I think more or less we went through all the details. Is there any comment, Elena, you would like to add regarding this stage and this particular, I would say, entity of prostate cancer? Regarding maybe one question you would like to raise to Professor Motet? I don't know if you can hear me. Can you?
Yeah, no, I can. Okay. I can. Yeah, I can hear you. No, I think he raises a very good point with the fact of where are we going if we start using PSMA PETs, whether this disease will still, this stage of the disease will still be there, or is just that we are not seeing the metastases that are already there, and if we don't see them, how relevant they are for the prognosis of the patient. Does it mean that the disease burden is not, I don't know, big enough, or the amount of disease will have different clinical implications than when we are able to detect just one bone met, for instance, right? And the other issue is that, the other thing is that I often don't know how to manage patients in the clinic with a PSA doubling time of 10.2 months. It's just, okay, come back in 4 weeks time and let's see if we are lucky. And then the PSA has moved as we want it to move. And then we repeat the calculation, and right. So sometimes this is, these are the issues that I also have to face in clinic. And I would like to say that I totally agree with what he said, that if we are considering tumor or germline testing for our patients with advanced disease, it doesn't matter if we don't see metastases at this point. It is already a good time to start considering this, because very likely for the purpose of germline and the purpose of, in this case, HR alterations for PARP inhibitors, that is what we have available, the alterations may not change. And we have already, we already know whether they are present or not, and we can prepare the picture of how are we going to manage that particular patient.
Perfect. Nicolas, one last final word from your side. Any other comments?
Yeah, two very simple ones. The first one is the non-metastatic CRPC is a stage that we created by using ADT. So probably we should think twice before using ADT in a non-metastatic patient. There are very clear guidelines for that, and it's not just because the PSA is rising that we have to use ADT. That's the first point. The second one is we need to be absolutely careful about PSMA. It's very attractive. It's absolutely attractive. but so far we have absolutely no outcome data based on treatment management. Why are we imaging patients? Because we individualize the treatment, because we have a better outcome based on a better stratification. All we have is based on old-fashioned imaging. Absolutely everything is based on that. PSMA is a wonderful tool that we still don't know exactly where and how to use. It might lead to major misuse and to major undertherapy.
Crystal clear. Thank you. I think it's time to close the session if we want to keep the timeline. Last few words we say from my side to thank the ladies in the office and especially Lotte Dobbelman from the school for organizing everything and making us very comfortable, I would say, as a scientific committee, but hopefully also for the attendees. We reached more than 200 live participants. The webinar will be available on a replay on the YouTube channel, and you can access through the social media network of the EAU. So do not hesitate also to give your feedback, and we would be more than happy together with Nicola and Elena to know what we can improve in the way we disseminate the knowledge, especially dealing with prostate cancer. Thanks again to Bayer for supporting this initiative. Enjoy your evening and see you soon on a new, I would say, Onco Euro event of the EAU. See you soon. Thank you.
Bye.